Hi, my name is Iza. I'll be presenting my case study, which is based on an undiagnosed term breach. So, I have Ruby, who is a primate, and she presented to MAFAO at 39 plus 6 weeks with suspected rupture of membranes and mild irregular contractions. She has had minimal antenatal care during this pregnancy, with last appointment with midwife being at 28 weeks. Pregnancy so far yet has been uncomplicated, all maternal obs within normal limits, and nil past medical history of concern. Abdo-palpation measures fundus at 35 centimeter with baby palping as breech, which is confirmed via ultrasound as RSA, which is right sacral anterior position and engaged. Fetal movements are normal, rupture of membranes are confirmed, with speculum and presence of thick meconium in liquor are noted. Vaginal examination shows cervix is long and closed, with CTG being normal, more than 2 accelerations present, contracting 1 to 2 in 10 minutes. And Ruby has been able to talk through the whole process. This also indicates that Ruby is in latent phase of labor. After seeing and assessing Ruby, there are a couple of concerns to be noted. With last antenatal appointment at 28 weeks, she hasn't had much care, which means there might be potentially unknown risk involved in her pregnancy. She is an undiagnosed term breach that classifies her as an emergency in a complex case. That means, or that also means that she has not been counseled by a midwife and obstetrician regarding breech pregnancy. She does not. She also does not have a third trimester scan that shows us fetal size and weight, breech position, and placenta presentation. Her GBS status will is unknown, so she will be treated as negative. An ECV at this stage is contraindicated as per the King Edwards guidelines. The breech position is unknown currently, so we don't know whether it's complete breech, frank, or a footling, as that will tell us if a vaginal birth is possible or not, if Ruby decides to proceed for a vaginal birth. And an obstetrician who is skilled in breech birth availability would need to be assessed, because as per the guidelines an skilled obstetrician in breech vaginal birth needs to be available. Also, breech has a risk of cord prolapse, head entrapment, fetal distress, birth trauma for the mother, and a possibility of requiring emergency C-section as per the guidelines. And also, to proceed with the breech vaginal birth, women have to meet a certain criteria as per the King Edwards guideline. Her rupture of membranes timing needs to be monitored, as if rupture of membranes have been ruptured for 24 hours or above, they become prolonged rupture of membrane, which increases the risk of intrauterine infection, and plus we would have to start prophylactic antibiotics. Thick meconium in liquor indicates that baby has done a poo, which is quite normal when baby becomes term. It is not an immediate issue. However, as time passes, the baby can inhale or aspirate on the meconium, which can cause difficulty breathing and cause baby to become distressed, which requires baby to be born immediately. And after birth, baby might need some help with airway or in worst case scenario resuscitation. Another issue immediately noted would be the fundal height being 35 centimeter. However, Miles' textbook from midwife states that from 36 weeks onwards, fundal height becomes less reliable as fetal head, or in this case the presenting part, descends and engages in the pelvis. Also, to confirm fetal growth and well-being at this stage requires an ultrasound. After analyzing Ruby's current situation, the main factor is she is an undiagnosed breech, which categorizes the situation as emergency. As per the King Edwards guideline, she will be treated as an emergency. Due to the risks involved with breech a breech pregnancy for both mother and baby. The fact is that she's had minimal antenatal care, with the last being at 28 weeks of gestation, means we don't have any third trimester ultrasound which shows fetal growth, placenta position, and plus we don't have any recent blood test result and GBS status. As there has been nil complication in pregnancy so far and CTG being normal, do we need to do a fetal growth scan at this stage? Requires discussion with coordinator and obstetrician. However, we still need to do another ultrasound as we don't know what kind of breech position baby is in. It's in the right sacral anterior RSA position, which is in a good position. However, we need to know if it's frank position, which means baby's legs are extended upward, or a complete breech position where baby's legs are crossed downwards from the knees, so there is no possibility of a vaginal birth at this stage and requires a C-section. Plus, we need to take into consideration that baby has done a poo. There is thick meconium in the uterus, which is not an immediate issue as the CTG was normal, so baby is doing fine. However, we are limited on time because we need to consider the fact there's a chance that baby can aspirate on the meconium and can go into distress. Also, membranes are ruptured, and if they become prolonged rupture of membranes, they can cause or lead to intrauterine infection and cause distress for the fetus, or in worst case scenario intrauterine death. Also, Ruby is in early phase of labor, so we do have some limited time to consider things and intervene with the best possible outcomes and make a better plan for her. A breech vaginal birth is possible if the baby is in optimal position, but there's still risk of cord prolapse. Baby can go into distress during labor, head entrapment, and birth trauma for Ruby. We also need to consider that we have an obstetrician skilled in breech vaginal birth available during delivery if Ruby opts for that route. Mainly, another thing is mainly Ruby's mental health needs to be considered as we do not know how she has been going through this pregnancy. I do not want to overwhelm her, so clear communication needs to be done with Ruby about what's happening, the situation at hand, the risk involved needs to be discussed, and she and her partner needs to be counseled by an obstetrician to make an informed decision. My management plan would be at this stage that I will first of all inform Ruby that as she is a breech and has meconium stained liquor, she will need to be continuously monitored on CTG for Bubby's well-being as per the guidelines from King Eddie's. I will put her on the wireless CTG if possible, so she is not restricted to bed. Then I will go immediately inform the coordinator about the situation at hand, about the undiagnosed breech, and then I will brief the obstetrician on the situation, have them go see Ruby, review Ruby, and have a discussion with her, and plus request them to do a bedside ultrasound to solidify baby's what breech position are they in. After that, I will go back into the room and I will clearly and have a clear and compassionate discussion with Ruby and her partner George about the situation. I will explain to her the risks involved with breech vaginal birth, such as risk of cord prolapse, head entrapment, fetal distress, birth trauma, and the possibility of requiring an emergency C-section. And I will also inform her about the success rate of a breech vaginal birth and the criteria required for it. Plus, with meconium stained liquor, there is a risk of baby aspiration can go into distress. I will educate her on that. I will explain to her why elective C-section is recommended as a safest option as per the clinical guidelines. I will impart this information on Ruby as I want Ruby and her partner George to understand the situation and make an informed decision about what kind of birth she would like to proceed with, as this is her pregnancy and she should understand what's happening. I will try to get an IV line access with Ruby's consent for fluid replacement if needed, oxytocin infusion if required, and in case if we have to go for an operative birth, elective or non-elective, so we have IV access. I will inform Ruby that since she does not have any recent blood test result, I will be taking some blood samples, sending them off for fresh results. That includes full blood count, UNEs, iron studies, and group and hold in case a blood transfusion is required, and antibody screen. If Ruby progresses into labor rapidly, then I will call for the appropriate skilled staff to assist in delivery. I will have the birth pack ready with episiotomy scissors in case if an episiotomy is required. Ergometrin or centrometrin will be ready on the side for active placenta management or in case PPH management. Have the pentacot ready for Bubby and request pediatrician's presence so baby can be assessed after delivery. Thank you.